Hello everyone, here is Dr. Guo Hongzhang from Department of Pathology, Shantou University Medical College. Today we are going to talk about the disease of the immune system. Normally, the immune system defends our body against invaders, such as virus, bacteria, and foreign bodies. Overactivity of the immune system could cause several disorders. In case of immune system overactivity, the body attacks its own tissue. On the other hand, immunodeficiency decreases the body's ability to fight pathogens, causing susceptibility to infections. The immune system will reject the transplanted organ as well. Therefore, the disturbance of the immune system comes in several forms, including auto disorders, immunodeficiencies, and rejection of transplants. In this session, we will discuss auto disease, acquired immunodeficiency, and transplantation pathology. Upon completion of this chapter, hopefully you will be able to define the auto disorder, describe the pathological changes for target organ, and list the types of autoantibody found in common autoimmune conditions. They are the learning objective for today's session. Describe the immune response in immunodeficiency and after transplantation. When the immune system is functioning normally, it recognizes harmful bacteria and virus and responds by creating antibodies that seek out and find them off. Autoimmunity is the presence of antibodies directed against normal tissue components. Those components are called self-antigens. The antibodies that recognize self-antigens are called autoantibody. In other words, autoimmune disorders are the results of a failure in the immune system to recognize self-antigens, resulting in production of antibodies that attacked normal tissue by mistake. Currently, autoimmune diseases are estimated to affect 2 to 5% of the population in developed countries. Autoimmune disease can be classified according to several criteria, one being the targets of the autoimmune attack. Referencing this criterion, autoimmune disorders are distinguished as systemic or organ-specific. Typical and common systemic autoimmune disorders are rheumatoid arthritis, systemic lupus erythematosus, scleroderma, and Sjogren's syndrome. Most of the autoimmune conditions are associated with one or more specific antibody. We will introduce the autoimmune disorder from these 5 aspects, including cause, organ and tissue affected, autoantibody, pathological changes, and clinical manifestation. Based on the incidence of autoimmune disease, we will first introduce the rheumatoid arthritis. Rheumatoid arthritis, often abbreviated as RA, arises more frequently in female than male, predominantly from 45 to 60 years of age. The prevalence rate ranges from 0.5 to 1% in the population. The specific cause of RA are still unknown. However, currently, we believe that it is a consequence of interaction between genetic risk factors and the environment and the immune system. Some factors, such as hormone level and viral infection, can increase the risk of the developing this disorder. As asthmatic arthritis, RA principally affects the small joint of the hands and feet, ankle, knee, and wrists. The joint damage is usually found on both sides of the body. Extra-articular lesion may occur in the skin, heart, blood vessel, and lungs. Rheumatoid factor and anti-citrullinated peptide antibodies are the specific antibodies for RA. Basically, antibodies attack the synovial lining of the joints, manifested as chronic papillary synovitis. Microscopically, we can find synovial cell hyperplasia and proliferation. Dense perivascular inflammatory cell infiltrates in the synovium composed of lymphocytes, plasma cells, and macrophage. Increased vascularity due to angiogenesis. Aggregates of organizing fibrin on the synovial surface and in the joint space. And increased osteoblast activity in the underlying bone, leading to synovial penetration and periarticular bone erosion. We define the abnormal tissue growth caused by thickening of the synovium as pannus, which is formed by proliferating synovium lining cell admixed with inflammatory cell, granulation tissues, and fibrous connective tissue. Pannus formation is a typical morphological change for RA. Pannus is Latin for cloth or garment. During earlier pannus formation, the synovial membrane develops microscopic projection called V-line on its surface. As it thickened tissue grows, it occupied the small space between the bone of the joint. This invasion caused the pannus to cover the bony surface and their articular cartilage. As the pannus develops, it takes up more space in the joint. Pannus also releases harmful enzymes, acids, and proteins that can damage the bone and cartilage within a joint. Finally, fibrous connective tissue replaces the pannus. Eventually, this connective tissue calcifies, leading to permanent damage and reduced mobility in the joint. Tissue damage can cause long-lasting or chronic pain, joint instability, and deformity. So overall, the RA process includes trigger, inflammation, joint and tissue destruction. Let's move in on the second autoimmune disorder, systemic lupus erythematosus, known as SLE for short. Is characterized by organ damage that results from the deposition of immunocomplex. SLE is a fairly common disease with a prevalence that may be as high as 0.4% in certain populations. The immunocomplex forms when autoantibodies are made against the nucleic acid and the protein constituents of the cell nucleus. Although the pathogenesis of SLE is still unknown, it's believed that UV irradiation and other environmental issues lead to the apoptosis of cells. Inadequate clearance of the cell nuclei results in a large burden of nuclear antigen. Lymphocytes are stimulated by the nuclear self-antigen, and antibodies are produced. Finally, these autoantibodies damage the tissue either directly or in the form of immunocomplex deposits. SLE may affect virtually any organ or structure of the body, especially the skin, kidney, joints, heart, and nervous system. Autoantibodies are made against the nucleic acid and the protein constituents of the cell nucleus, called anti-nuclear antibodies, that could be found in nearly all individuals with SLE. Anti-nuclear antibodies have several types, including anti-double-stranded DNA and anti-SM antibodies. Pathological changes in SLE are characterized by organ damage that results from the deposition of immunocomplex. The skin is involved in the majority of SLE patients. They present with a characteristic erythematous or maculopapular eruption over the malar eminence and the bridge of the nose, which we call the butterfly rash. Under the microscope, we can find the immunocomplex deposits at the basement of the affected skin. Up to 50% of SLE patients have clinically significant renal involvement associated with the deposition of the immunocomplex within the glomeruli. The clinical presentation of the SLE is highly variable, and it has many overlaps with other autoimmune diseases. For details, please refer to relevant learning resources. Sjogren syndrome is the third most common rheumatic disorder after RA and SLE. The patient presents typically with dry mouth and dry eyes, resulting from immunological mediated destruction of the lacrimal and salivary glands. Female to male ratio is 9:1, with average age of onset between 40 to 60 years. Eyes and mouth are the target organ of the autoantibodies. Specifically, the mucous membrane and the secreting glands of your eyes and the mouth are affected, resulting in decreased tears and saliva. Other organs, such as skin and the vaginal also may be involved. Antibodies against the two ribonuclear protein antigens, SSA, SSB, can be detected in almost 19% of patients with Sjogren syndrome. Infiltrating of lymphocytes and plasma cells leading to enlargement of the parotid or other salivary glands. The lymphocytic infiltrating becomes more extensive, and in the large salivary glands, lymphonoid follicle with germinal center could be identified. The epithelial cell lining the duct may become hyperplastic and obstruct the duct lumens. Later, there is atrophy of the acini fibrosis and hyalinization. The atrophic parenchyma may be replaced with fat. The patient may complain of burning, itch, and gritty eyes. Her mouth may feel like it's full of cotton, making it difficult to swallow or speak. Sjogren syndrome occurs as an isolated disorder or often accompanied with immune system disorder, such as RA and SLE. Here we have provided some knowledge about the autoimmune disorders. Instead of producing antibodies that attack infection organism. The body produces antibody called autoantibodies that react with components of the body's own tissue. They are the reference, and thank you for your attention.